Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of having on the podcast Dr. Tyler Hillman, who is at UC San Diego in San Diego, California, and Dr. Allison Brodsky, who is now third-year fellow in the Department of Gynecologic Oncology and Reproductive Medicine at the University of Texas MD Anderson Cancer Center here in Houston, Texas. And today on this podcast, we're going to be talking about a recent publication in the American Journal of Obstetrics and Gynecology titled Survival Outcomes Comparing Minimally Invasive versus Open Cytoreductive Surgery in Recurrent Adult Type Granulosa Cell Tumors. Allison, thank you so much for accepting this invitation. Welcome to the podcast.
Thank you so much for having me.
And Tyler, always great to see you. Congratulations on your new venture at the University of California in San Diego. Certainly, always jealous of having somebody in that city and having that city as your place of work.
Yeah, well, thank you so much for the invitation.
Well, as we want to discuss this topic, I wanted to just start by asking, what led you and your team to explore this question? Why would the surgical matter in the surgical approach matter in the setting of recurrent adult granulosa cell tumor?
It's a great question. I think a lot of the times with these rare tumors, they get lumped together with other tumors and we manage them as such. And we know that for endometrial cancer, for example, there was both the LACE and LAP2 trial showing no difference in minimally invasive versus open surgery in early endometrial. There was the LAC trial, which I'm sure you know about, Dr. Ramirez, which showed that there was a difference for cervical cancer. And then there's an ongoing trial right now for epithelial ovarian cancer called the LANCE trial that's looking at interval debulking, open versus minimally invasive. And so, we kind of lump granulosa cell with ovarian epithelial, but it acts quite differently. And a recent work by our group, by Jeffrey Howe, had shown that recurrent granulosa cell, if resectable, has with subsequent surgeries up to surgery site reduction, had significant improvement in PFS and OS compared to those who were treated medically. And so we thought it'd be a good question to see if these surgeries should be done open or minimally invasively.
Excellent. So with that introduction, we'll get into the question about study design, inclusion criteria for this particular study, and also what were your endpoints?
Yeah. So this was a retrospective cohort study. We're lucky at MD Anderson to have a rare gynecologic malignancy registry where we register patients with rare tumors so that we can have a large volume of cases. And so we wanted to look at, in this registry, anyone with an adult granulosa cell tumor who had at least one documented recurrence. And then we excluded patients who had disease refractory to frontline treatment, or if their recurrence wasn't driven by the granulosa cell portion of a mixed tumor. And the overall primary endpoint was to examine the associations between surgical approach, clinical variables, and survival outcomes, comparing patients who had minimally invasive versus open surgery at their first recurrence for adult type granulosa cell tumors.
Great. Large study for this rare tumor, 485 patients with adult granulosa cell tumors identified, 108 meeting your inclusion criteria. So what were the results of the study and the main points that you would like to highlight for the audience?
Yeah, I think the good things to know, as you mentioned, we had 108 patients that met all our inclusion criteria, which included having operative notes that we could review in recent imaging. And 72% of our patients had open surgery at their first recurrence, whereas 28 had minimally invasive, and it was about a 50-50 split between robotic and laparoscopy. We had noticed that patients who were younger and who had their initial surgery done in the minimally invasive approach tended to have higher rates of minimally invasive surgeries compared to their older counterparts or those who had an initial open cytoreductive surgery. And we found that patients with multifocal disease or extrapelvic disease were more likely to have an open approach at recurrence. We also briefly looked at conversion from MIS to open and why that occurred, although that population was small with an N of 11. But we did see that significant disease burden was the main reason for conversion. And I think the biggest takeaway is that between the two groups, there was no difference in rates of complete soda reduction. There were no difference in rates of adjuvant therapy, no difference in port site or incisional mets, but we did see higher surgical complexity in the open cohort group, which wasn't very surprising. But despite this, there was no difference in progression-free survival after first recurrence and no difference in overall survival. And that maintained true after a multivariable analysis that looked at age, surgical approach, extent of disease, the year the surgery was done. So we found that the values held up.
Excellent. So thank you so much, Allison, for providing the highlights of the result. And Tyler, Allison, as you know, many of the questions for these podcasts come from our fellows in the journal. So we'll start with Filippo Capomacchia from Italy. And his question is, your Cox model adjusted for age, year, and disease extent, given baseline imbalances, did you also adjust for prior surgical route at diagnosis and for post-recurrence adjuvant therapy to reduce confounding by indication?
It's a great question, and I think there were a lot of different variables that we could have used in our Cox model. We didn't use what Filippo specifically asked. We didn't look at prior surgical group or post-recurrence adjuvant therapy because those didn't seem statistically significant in our single variable analysis, and we didn't want to overfit the model with too many covariates. You know, we were missing patients, we were missing data from some patients. So for the Cox model was only 54 patients. So I think having too many variables could have led to overfitting and inaccurate results.
Great.
I would also
Yeah,
say,
go ahead.
just to chime in, that the year of their surgery seemed to have a correlation with the modality of their original surgery, just because of the temporal adoption and comfort level with laparoscopy for these kind of cases. So some of that was, we felt, captured in the model as it was constructed.
Yeah, interesting. Yes, and typically, yes, such is the case with this sequential implementation of surgical approaches. This next question also from Italy, Sofia Bigardi, and she's asking about patient selection. She says the open surgery group had higher surgical complexity scores, and some minimally invasive procedures required conversions to open surgery. What does this tell us about the importance of preoperative assessment in patient selection?
I think it just highlights the careful need for considering all aspects of your patient when choosing minimally invasive versus open, such similarly to what we do in epithelial ovarian cancer debulking, interval debulking surgeries. You know, we had mentioned in our article that potentially a candidate for further research would be to establish criteria to determine candidacy for MIS versus open, similar to like the PCI score. You could always consider scope and score approaches similar to ovarian cancer as well at the time of surgery.
I think these things are hard to untangle with the retrospective design always, and short of a prospective trial that has really specific criteria for enrollment and resectability, I think what we're able to say is there does not appear to be a very clear safety detriment to the oncologic outcomes with MIS, as long as it's a well-selected population.
Yeah. Alison, you mentioned the PCI. Natalia Tejeda from Barcelona, she's asking, disease volume plays a key role in determining whether a minimally invasive approach is feasible in recurrent cases. Did you have access to any objective measures of tumor burden, such as the peritoneal cancer index PCI, or similar scoring systems to support the choice of surgical approach in your study?
I wish we did, but unfortunately not. Since the study was retrospective, we didn't have any type of PCI scoring or intraoperative scoring, and we didn't want to try to extrapolate this from operative notes. Given this approach wasn't taken, there wouldn't be a clear score, and we would kind of be making that score on our own based on words rather than being there in the surgery. So therefore, we decided to determine surgical complexity in our paper just based on the actual surgeries that were performed, because it was very clear from operative notes, at least what if there was diaphragmatic stripping, if there was bowel resection, that was clearly something we could take. So really for complexity, we used imaging findings prior to surgery and then what surgery was performed. And as I mentioned, it would probably have to be a prospective study if we wanted to use some type of scoring method.
Great. Now let's talk about tumor markers. Mariana Carvalho from Sao Paulo, Brazil. She's asking, surveillance of adult type granulosa cell tumor often includes biomarkers such as inhibin A. Were inhibin levels evaluated for the patients in your study? And if so, did they influence surgical decision making, or should they influence surgical decision making?
So they weren't used in our study, and I think there were two reasons. One is, again, because of the retrospective nature. A lot of our patients' first surgeries, and even sometimes their second surgeries, were done at outside institutions, and it was hard to find inhibin levels that correlated with time of surgery. But secondary, again, I don't love to compare to epithelial ovarian cancer, but if you have a rising CA-125 level, that wouldn't really determine if you would do surgery or not. It's going to be the imaging findings that would dictate A, if surgery is feasible, and if so, your approach. So we didn't think that would add anything that would directly impact surgical decision making.
I would think in my experience, the inhibin B especially has a relatively loose relationship to disease burden, and I've seen quite large variations between patients in terms of the level of those tumor markers and their actual radiographic disease burden.
Great. Another question from Mariana. This one pertains to age and frailty. And she says, your study found that patients undergoing minimally invasive surgery at recurrence were significantly younger than those treated with open surgery. Given that minimally invasive techniques can reduce morbidity and speed recovery, potentially offering greater benefits to older patients, what factors do you think explain this age difference?
I think one factor which we didn't look at specifically is that the patients who are older in their second recurrence, this disease can recur years to 20 years later. And potentially the reasons older patients had more open surgeries was, like Dr. Hillman had said earlier, laparoscopy just hadn't come on yet, and physicians weren't as comfortable with it. So it again could be a variable that's confounded by the year given their age. Because I do think that minimally invasive surgery is a great option for our older patients based on recovery.
Excellent. Elena Obermeyer from Sydney, Australia. I know this is an area of interest to her. She's asking, the rates of port site metastases were 8.3% in the MIS group, and interestingly, 7.4% in the open group. How does the risk of port site or incisional metastases influence your decision-making when considering a minimally invasive approach? Does that differ between adult granulosa cell tumors and epithelial cancers?
Yeah, I think it's certainly, whenever I'm doing laparoscopy on someone with a proven malignancy or even suspected malignancy, it's certainly part of the informed consent process to discuss the risk of port site or incisional metastases. We found that they were relatively similar between our two groups. Historical data, which there's some caveats, but historical data from epithelial ovarian, mostly from when laparoscopic techniques for assessment of resectability were being developed. I found some reports of even higher rates of port site metastases, up to 17%. Now, given that's a very different situation, there's often carcinomatosis or ascites, which is infrequent in recurrent granulosa cell tumor, that may raise that rate. But I think it does compare favorably with some of the historical data on port site metastases in epithelial.
Right. So now I want to ask you, and this actually is a theme question because several fellows had this question in some way or another. And they say, in your study, many patients who underwent open surgery had more extensive multi-site recurrences and had open surgery at first diagnosis, whereas the MIS group often had single-site pelvic disease and MIS at first diagnosis. So how do you see this impacting the comparison and outcomes? Do you think it's possible that we're looking at two very different clinical scenarios rather than comparing two different surgical approaches?
Yeah, I think the first thing to mention is that our data doesn't specifically look at characteristics of the initial surgery. So while we have a few things such as age, approach, and stage, I don't know the degree of which that was done because the requirement for the study was the operative report from the first recurrence, not the initial surgery. However, I think it's important to note that for both groups, 72% in the open cytoreductive surgery at first recurrence and 81% in the minimally invasive group at first recurrence, they were stage one. So that means that these patients at their initial surgery most likely just had a laparoscopic or open USO, maybe BSO, hist at most. But for stage one, sex cord stromal tumors, we don't do lymph nodes, we don't do omental surgery, bowel surgery. So I think for the majority of these cases at stage one, the disease was confined to the ovary. So I'm not sure we're really looking at different clinical scenarios. I think a lot of the time we don't know. It's just a large pelvic mass, and a lot of these are diagnosed after surgery, and that could be the reason for the differences.
This question comes from Rim Abu Chakra in Lebanon. It's about the PFS2, progression-free survival 2, which in your study was defined from first recurrence to second recurrence or death. She's asking, the PFS2 curves overlapped for both open and minimally invasive surgeries, but the median PFS was 26 months versus 21 months. So is that difference large enough to really matter in patient outcomes?
I would say any time without disease is important for a patient because it can be time without treatment, and I think that's important. And if you look at recurrent epithelial ovarian cancer, we're looking at 3 versus 5 months and changing treatment parameters based on that. I think, though, for overall, given that this is retrospective and a small cohort of 108 patients, what we need to take away from the PFS2 value is not exactly the numbers, but that there's statistically no significant difference and that we can potentially say these surgeries have similar recurrence outcomes and not necessarily use the values to quote times until next recurrence with patients.
Okay. Another question from Reem. She's asking, given that extra pelvic and widespread disease, usually surgery went to open, how sure can we be that the similar survival rates aren't simply the reflection of disease burden driving the surgical choice?
That's a good question. I think those are the hardest things in these kind of studies to untangle, is the factors that play into selection, and whether you're looking at two different populations or different disease biology. So obviously we can't, I think, answer that in a definitive way with this data set. But I think, based on a surgeon's assessment and their belief in their skill to be able to cytoreduce what they're seeing on imaging, I think our data supports the selection of MIS route, when that's deemed feasible in that clinical setting.
Yeah. Another question back to Sofia Bigardi from Italy. She's asking, beyond survival outcomes, how should factors like recovery time, postoperative morbidity, quality of life, cosmetic results influence the choice of surgical approach?
I think all of them are very important, both to physicians and to patients. And I think a quicker recovery time with less postoperative morbidity, if safe and feasible, is something that a patient is probably going to choose 9 times out of 10. And so it needs to highly be considered when choosing your mode of surgery. So I think if this paper is showing that we're having similar survival and recurrence-free outcomes, the real question is, does a surgeon think it's feasible for them? Because I think if you, with confidence, tell a patient that you can do it minimally invasive versus open, the majority are going to choose minimally invasively.
Yeah. Going to a question from Luisa Prope, University Hospital, Münster, Germany. Given that complete cytoreduction rates were similar, do you attribute this to careful patient selection, surgical expertise, or characteristics inherent to the tumor itself?
Well, what's interesting, oh, sorry, go ahead,
Yeah.
Doctor.
No, go ahead.
I was going to say what's interesting is that, a lot of patients come to MD Anderson for second opinions after multiple lines of therapy. So this study isn't looking at physicians who are just performing surgery at MD Anderson. This is actually encompassing a wide geographic variety. So I don't necessarily say that we can chalk it up to surgical expertise or being like at a cancer center alone. I do really think it's choosing the correct surgical approach, evaluating the imaging, and deciding what you need to do to be able to get someone to R0, because we've seen time and time with granulosa cell tumors, complete cytoreduction is one of the most important factors for their survival outcomes. And again, while the numbers were small, of the 11 patients converted from minimally invasive to open, 73% of them were due to feasibility and the inability to do complete cytoreduction without opening. And so I think it's really just careful patient selection.
Great. And Tyler, were you
And,
going to add anything to that?
I was just going to echo that. I was just going to say all of the above. I think it's hard, there's disease related, center related, surgeon related factors that are all uncontrolled in this setting.
Excellent. So Natalia Tejeda from Barcelona, Spain, she's asking, given that minimally invasive surgery appears oncologically safe and is widely accessible nowadays, what objective and specific recommendations would you make regarding patient selection for MIS in cases of recurrent granulosa cell tumors?
I think personally, one of the ways that I could see operationalizing this finding is to have a very low threshold to perform a diagnostic laparoscopy prior to embarking on a cytoreductive attempt, because I think that gives you a very clear sense of feasibility above beyond the radiographic information. And, if it's feasible, I think then our data support proceeding with a laparoscopic resection at that point. So being prepared, to perform open surgery if necessary to achieve the optimal complete gross cytoreduction, but a diagnostic laparoscopy, I think, is a very reasonable thing to consider for these patients.
Great. Filippo Capomacchia from Italy, he's asking then as a follow-up actually to your answer, if you had to propose a pragmatic selection algorithm today, which preoperative features like single site of pelvic disease, prior MIS, expected low complexity would push you towards minimally invasive surgery, and which would argue for straight to laparotomy?
I think the folks where we've moved directly to laparotomy are those who have extensive or multifocal, especially upper abdominal disease, usually where I'm involving other surgical subspecialties, hepatobiliary or other, to help with the cytoreductive attempt. It's very rare that we would consider doing those via MIS approach. So I think it would be possible to develop a formal algorithm. That's an interesting area of research, but I think also just a careful review of the pre-op imaging and then judicious use of a diagnostic laparoscopy in cases where cytoreduction seems feasible may substitute for something more formal, or where an algorithm may be difficult to develop for this rare tumor.
Excellent. So now we come to our last question. We have a new tradition in IJGC podcast, and that last question comes from AI. And basically, after artificial intelligence read your paper, it came up with this question. If optimal cytoreduction rates and survival outcomes are essentially the same between minimally invasive surgery and open approaches, are we overvaluing surgical aggressiveness in adult granulosa cell tumor recurrence instead of acknowledging the simple fact that biology, not the extent of debulking, may ultimately dictate prognosis? Pretty good question from AI.
That's a pretty good question. You want to tackle that?
Yeah, I think, again, this kind of refers to the paper by our group as well, written by Dr. Jeffrey Howe, where, the title of the paper is looking at serial cytoreductive surgery and survival outcomes in return adult type granulosa cell tumors, which was also published in AJOG. And what he found is exactly addressing this question. Cytoreductive surgery at primary, secondary, and tertiary recurrences significantly improved progression-free survival and overall survival compared to medical treatment. And it trended towards significance as well at the third recurrence. So I think there is definitely a benefit to surgical resection and surgical aggressiveness in these tumors. And that is part of their biology, right? They don't respond to chemotherapy as well as other drugs. And so it is their biology, but I don't think we're overvaluing the surgical aggressiveness.
Allison, I think you did a fantastic job answering to AI on that point. So
Thank you.
really, congratulations. Tyler, anything you would like to add?
No, I think that was a great answer to a great question.
Well, thank you both so much again for accepting our invitation. Congratulations on accomplishing this work and really very important work that you are doing in rare tumors. Really commendable, because oftentimes these are tumors that are not prioritized for asking these important questions. So thank you both, and to the rest of your co-authors, congratulations. And look forward to hopefully additional podcasts in the future. Thank you for your time.
Thank you.
Thanks for having us.